Next session, we have with us Dr.R. Rathinamala. Madam holds an MD in Siddha Pharmacology from Government Siddha Medical College, and she has also pursued her MPhil and PhD degree. She is presently working as a research officer at the Siddha Central Research Institute, Chennai. She has got extensive research experience in the field of teaching and clinical practice also. Dr. Rathinamala has authored many scientific articles published in reputed and peer-reviewed national and international journals, and also has been authored chapters in books and a book. She has participated in various seminars, conferences, and live TV programs in Doordarshan and radio channels as a subject expert. Her research interests include drug standardization, drug development, clinical research in certain skin diseases, to name a few. Over to you, ma'am.
Some of the views on orientation on metabolic disorders, diabetes mellitus, non-alcoholic fatty liver disease, and obesity through Siddha. Being a Siddha physician, I think I'm not going to teach you anything new. Just a recap. So, outline of my presentation is covers the introduction about metabolic disorder, why we need STG. Already, Dr. Raghu sir has given a detailed lecture, and recap of type 2 diabetes mellitus, obesity, non-alcoholic fatty liver disease. These recaps have covered from the prevalence of these diseases and what are all the diagnostic criteria and what are all the investigations we have to do. What are the essential investigations? What are all the advanced investigations we have to do, and the prevention management, and as well as the interventions we have to do. The same time, we have to follow the referral criteria. Before starting it, we must know the red flag signs. These are all the criteria I have covered for all these things, and the Siddha ethical principles of management and follow up how to do, and what is the ultimate goal, that is take home message. The first one, everyone knows that the metabolic disorders is a heterogeneous group of diseases. That is, any metabolism, is there a failure in the metabolic pathways or intermediary metabolism which can be inherited. That means we are all speaking about the carbohydrate, protein, lipid, but it may be also having inheritance. So inherited or arise from spontaneous mutations, what we are dealing with now, and leading to multiple system manifestations and affecting energy usage and storage from alimentation. These are all grouped under metabolic disorders. We all already know that carbohydrate, protein, lipid, minerals, these are all the common metabolism we are coming up, and the diseases type 2 diabetes mellitus, obesity, dyslipidemia, NAFLD, gout, what we are having in the hand, STG covers these things. And other than that, hypothyroidism, hyperthyroidism, homocystinuria, etc. There are a lot of metabolic disorders, inheritance metabolic disorders also there. Why we need STG? For Siddha system. Already Dr. DDG sir already explained in a detailed manner, so I am not going in a detailed manner, just to ensure uniformity in clinical practice. Being a Siddha physician, we know our uniqueness of treatment, because every physician is having their own rules and regulations, and they may follow their own medicines, their own line of treatment and all. But when we are coming to globalization, when we want to synthesize evidence-based treatment protocols, automatically we need an uniformity. For that uniformity in clinical practice, this STG has emerges, and which will enhance the safety and efficacy, and you can share the knowledge that I have treated the patient with this STG and I got this result, then why can't you treat it? Then we may have the results in a sustained manner. And next one is, this will facilitate us to integrate with the mainstream healthcare. If suppose already you all have spoken about the NAM scheme and you are practicing with the modern practitioners, and it will be helpful for you once you are generating an evidence-based reports. Automatically it will be helpful to integrate our system to mainstream healthcare, which strengthen the research as well as educate. education. This research and education will support the policy makers. Why we are here? It will develop a policy, it will be helpful for the policy makers. Thus these things are happening according to the SDG. Then the next policy maker will take a decision, and it will be give us a chance to enter into the public health programs, which is our even though it is in the policy, but we are not entering into it. So then only we can build the global credibility and acceptance. Coming to the first one, type 2 diabetes mellitus. I have given some of the pointers there. Which one? This one, no? Okay. So you can see some of the letters I have mentioned just to highlight what it is. The first one, 8. What is it? We are all treating a lot of diabetic patients, seeing lot of diabetic cases in our, even in our relations and all. Diabetes, the 8th leading mortality for all over the world, it is in 8th place. And what is 80? 80 is the actually 80 percentage of the people are from low and middle income countries. These news is very shocking that we are also coming under the middle income country. 80 percentage of people of diabetes are from low and middle income countries. What is the prevalence of diabetes in India? Up to the India B study done by ICMR in 2019-21, it has been shown that I am highlighting only above 20 years. I am not showing the complete data. The people in the age of above 20 years, almost 15 to 30 percentage are in dysglycemia. That means they are not diabetic. They are in the state of pre-diabetic. And in this, 11.4 percentage of people are having diabetes. Have you just think it of our young generation? We are saying that we are the very big human resource all over the world. But if our successor are not in a healthy state, just think of the state. It is in the, I am saying about the 2020 data. Almost 5 years was over. What is the real scenario of today? The next one is after COVID-19, it has been increased to 14.44 percentage of people who are newly diagnosed as diabetic because of the COVID-19 manifestation. So this is the real scenario what we are having today. When coming to our system, that is everyone knows that Madhumeham, that is type 2 diabetes mellitus, I have mentioned the ICD code, the 5811. Why I have been mentioned, whenever you are diagnosing a diabetes, automatically please document it. Unless otherwise we are all doing a very good service, but we are very poor in documenting. So when you are documenting with the code, automatically it will reflect in the global scenario. In Siddha, these are all the, already you all very well know that it has been classified under the alal type of நீரிணை பெருக்கல் நோய்கள், which has been mentioned in the classical literature, Yugi Vaidya Sintamani. So it says that frequency of urination and gradual deterioration of the 7 body constituents followed by emaciation. This is the symptom we have. It has been mentioned in Yugi Vaidya Sintamani. And 10 stages of Madhumeha Avathaigal, that is complications of over the period, the patient may get the Madhumeha Avathaigal, that is diabetic complication. Coming to biomedicine, the chronic disorder resulting from aberrations in insulin secretion or insulin action or both maybe. So the long-term disease lead to macrovascular complication and microvascular complication. These things we know. What about the emerging complication? Some of the cancers like pancreatic cancer, colorectal cancer, these are all the emerging complications, as well as the people who are not working properly, that is some difficulty when we are doing their work, and sleep as apnea. These are all the emerging complications. Nowadays it is considered, and the complications rate is quite increasing. What is the diagnosis? When coming to diagnosis, the diagnosis based on laboratory investigations we know very well, and this is blood sugar level. When it is in the the diabetes, when the HbA1c, HB HbA1c is automatically 6.5 or higher. At the same time, 5.7 to 6.4 is considered as pre-diabetic. The fasting blood sugar is more than 126 milligram per deciliter, as well as the random blood sugar is more than more or less, equal to 200 milligram per deciliter. If suppose one of your patient is having this criteria, automatically if it is new, again you have to do it well, you have repeat it once, and you have to confirm that whether the patient is in the pre-diabetic condition or in the diabetic condition. So once you have completed the blood investigations, automatically you will go for a physical examination. This physical examination is not only to identify the diabetic complications, it has to be identified what are all the present comorbid condition the patient is having, including the fundoscopy and overall the health status as well as the mental status of the patients. Though this will be helpful to assess the diabetes as well as the the diabetic complications. So what are all the points to be remembered? So once the patient has come, you have examined the patient, you have done the laboratory investigations, and you have confirmed that the patient is having diabetes. So before initiating the treatment, you must ensure these red flags. That is, these points to be remembered, that whether the patient is having any hypoglycemic episodes, hyponatremia, severe cardiovascular disease including valvular or ischemic heart disease, any cerebrovascular accident, is there any other infective morbidity like pneumonia, tuberculosis, sepsis, just like infective cases, and any conditions of advanced stages of malignancy, and visual loss due to diabetic retinopathy, severe motor or autonomic dysfunction, renal dysfunction, or if suppose the GFR is reduced, diabetic ketoacidosis or hyperosmolar non-ketotic coma. These are all the points to be remembered before initiating the treatment. These have been mentioned in the STG itself. And what are all the settings? The settings is absolutely what are all the facilities you are having. There is no restriction to give the management. What are all the facilities you are having? If suppose you are having a level 1, that is, it's a simple physician clinic, we are having a PHC, we have only optimal standard of treatment in a situation where technology and resources are very limited. This is considered as level 1, which has been mentioned in the STG. And what is level 2? Level 2 is CHE, a small hospital which has 10 to 20 bedded hospital with the basic amenities like routine investigations, X-ray and all. And level 3 is an eyes hospital attached with teaching institution or any other multi-speciality hospital which is having multiple departments, facilities for diagnosis and interventions are considered as level 3. So this treatment protocol has been designed according to the level of facilities you are having. There is no restriction that I am in the level of 1, I can't use the level medicine which is mentioned in the level 3. It is not like that. It is mentioned here only about the facilities what you are having, how you can do it. If suppose you are in the level 1, then I couldn't do a podithimirtal or anything like that, I couldn't do, then you can move ahead to the level 2 and all. So our main motto is to prevent disease. That's all. Our system is also highlighting what is prevention, and prevention always the first step in Siddha. The first one is whenever is possible, just go ahead with the opportunistic screening. You don't hesitate for that. If the patient is coming above 18 years of age and he is having the history of any emaciation or any, just don't think that the patient is only 18 years old, why I am going with diabetes screening and all. Just wherever it is possible, just go ahead. And persons with a high BMI, surely you have to do, and women with a history of gestational diabetes, And first, any family history, hypertensive individuals, sedentary lifestyles, and any other insulin resistance or conditions associated with the insulin resistance, acanthosis nigricans, hypertension, dyslipidemia, PCOD, or for gestational growth is very minimal, then you have to go ahead with the opportunistic scanning. And next one is yogam and pranayamam. And yogam, I know very well, lot of yoga specialists are here. Some of the yogasanams which have been mentioned in the book I have quoted here, from Trigonasana, Surya Namaskaram, Tadasana, Vagrasana, like that, and pranayamam and dhyanam. And Therian Pinyanaka Vidhi, which is our strength, you have to educate the patient what are all the rules to be followed for dietary practices as well as lifestyle practices to be followed. These are all the things where we can stand. Our tradition, that is the traditional rice varieties. There are a lot of studies are available where we can stand. Mapale Chamba has been mentioned in our book that it is having exclusive use in the diabetes, as far as the meals which possess the 6 taste and millet diet, and advise the patient to take millet diet. Everyone is taking millet diet, not a fond for millet diet. At the same time, ask them to take as a khichdi or rice and all. When some of the studies have been highlighted that when they are taking it as a porridge, lot of the people are taking porridge. The porridge again, it will be powder, and when they are taking something, automatically it will again raise the glucose level. So educate the patient to take them as a wholesome grain in the lunch, or it may be having its upma or pongal, like that. Don't educate them to take it as a porridge. Everyone says that ragi kanji, ragi kul, like that. So please avoid those type of food items. And once these are all done, then we'll be having a physical activity. Physical activity, yoga, both can be done as according to the condition of the patient. If the patient they are very weak and they can't do that, then slowly increase them. Unless otherwise they are not using themselves, they can find the results. They won't accept what you are telling. So 30 minutes per day, 5 weeks per week. So you can say that you can have a 2 days holidays for a week. Then you can go ahead for 5 days. Then automatically people will enjoying the doing physical activity. And Varmam, they are having some Varmam points have been mentioned. You can try those points for managing diabetes mellitus. So what are all the management? So we have completed the prevention. When coming to management, as far as we all know that being Siddha physician, we are taught starting with the detoxification processes. So which humor is deranged, then we have to ensure that what is the real body constitution of the patient. Then you can go ahead with Ennai Kuliyal or Kalichal Maruthuvam, which have been mentioned, and the options of the medicines have been mentioned in the STG. And first line of treatment will be detoxification process. Once it has been completed, then we can move ahead with the treatment with single herbs. Single herbs we have mentioned, these are all the herbs have been mentioned in our book, that is Avarai, Kovai, Nileppanai Ver, Churanam, Kalyana Murukku, Tottachuringi, Peerku. So you can try these as a single herbs. And the compound formulation, we are having a lot of formulation which have been mentioned in the essential drug list. Avarai Kudineer, Sindil Kudineer, Madhumega Churanam, Kadalalinjil Churanam, Sanjeevi Churanam. So you can try your medicines, but availability and sustainable availability of the medicines to be taken care before starting the treatment. So even though we have suggested these are all the medicines, but the administration of the medicine, dosage, drug holiday, if you want to give any metals and minerals, and duration may vary according to the physician. Treating physician, it is absolutely lay on your freedom only. So this only depends upon the discretion of your treating Siddha physician. So we are quoting in this in a rightly manner in the treatment before giving the treatment and all. So before starting it, you are having your own discretion and how to choose which medicine to choose and how long you have to give, how to follow up. Everything will be stand by your side only. And what is the referral criteria? So the referral criteria when you are having non-response to treatment. There is no response. You are treating the patient for more than 1 month, 1.5 months. The blood sugar level is not coming under control. There is no use of further continuing the medicine. And target organ involvement and investigations have revealed something else, then you have to stick on. And complications of diabetes mellitus, including macro, micro or emerging complications, you have find something. And complications related to glycemic control, including uncontrolled hyperglycemia and frequent hypoglycemia. Being a Siddha patient, we think that our drug will not cause any hypoglycemic effect. Don't think like that. Even our drug can cause hypoglycemia. So be sure that whether you are having the follow-up, ensure that what is our drug is doing to the our patient too. So please be ensured, and substantial impact on their quality of life and any activities of daily living. If the patient is not comfortable with our medicine, you are giving Avare Kudineer Churnam and the patient is not comfortable to taking Kudineer Churnam, then you have to think of some other options to change the drug. Don't insist the patient to take that one alone. Again, he will leave the medicine or he may not take, and he will say that I am taking the medicine. So please be ensured that the impact of their quality of life and diagnostic uncertainty. If you are not having the confidence that whether I am doing the right thing, then just move ahead and follow up to be done as per the need. If suppose you are giving some medicine, you need 15 days. We have mentioned it 7 days as well for the leaves, but you can make it your own, that it can be a 15 days or 21 days like that, depending upon the condition as well as the patient's requirement. So we have finished off. Next we are moving to obesity. So obesity, everyone knows that even though this overweight and obesity criteria has been clearly mentioned about only for Asia Pacific region. That's why I am quoting here. The BMI, once it crosses 23 kg per meter squared, automatically they are overweight. When it crosses 25, automatically it is called as obesity. So this obesity will cause us lot of risk for non-communicable disease, a very big threat, and it has been mentioned as Thula Noi and Noodle Pariman in Siddha. So what is this? All over world, you know, any idea about how much of for which person, how many persons one is obese? Any idea? Anyone come across? Anyone read this? No, 1 in 4 is for India. That's why I am not mentioning there. Actually, all over world, 1 in 8 is obese. 9. Okay. So up to NFS National Family Health Survey 5 2020, it shows that 1 in 4 of Indians have obesity. And 135 million people of Indians are obese. Okay. And when coming to the abdominal obesity, this is the very big issue for Indians mainly. And you can see the prevalence, 40% of female are having abdominal obesity, which is only 12% in male. Maybe the reason for pregnancy and all, but this has to be ensured and this has to be addressed in a right manner. And when coming to the childhood obesity, the global scenario according to 2022 scenario, the overweight, that is under 5, it is 37 million children. When coming to 5 years to 19 years, over 390 million children are obese, as well as in that 160, that is overweight, 390 million are overweight totally, and in which 160 million are obese. This is the real scenario of global scenario. And what is 75%? I have mentioned 80%, just like 75% of obese individuals are living in low and middle income country. Right? So what are all the assessment in overweight and obese persons? We are having 4 indicators. The first one is clinical based obesity indicator. What are they? These are body mass index, waist circumference and waist to hip ratio. And the next one is investigation based obese indicators. So what are all the investigation, basic investigations as well as advanced, both have been mentioned in the chart. And the next one is history based. Sometimes how the weight has been gained, whether it is a slow, insidious weight gain or fast weight gain. It has been mentioned in the body weight history, how they have gained the weight. The next one is family history of obesity. The third one is drug history. If suppose the patient is having any hormonal medicines, or they have taken any antipsychotics, if suppose they are having anti-epileptic drugs or any steroids, then it has to be clearly ruled out. And illness history, if suppose they are having any recent illness, then it has to be mentioned. And what are all the imaging based obesity indicators? We need dual energy X-ray absorptiometry and MRI and body composition analysis. So these are all the techniques. Other than that, we are having advanced investigations, that is 24-hour urine free cortisol, electrolyte panel test, ECG and X-ray, respiratory function test, LFT, USG whole abdomen, plasma leptin to identify the level of hunger, and test for insulin resistance and hormonal assay, especially for females. So these are all the diagnostic criteria we are having. So the proposed classification of weight by BMI in adults, already we have told that 8.5 to 22.9 is the normal one. So above 23 to 24.9 is overweight. Once it crossed 25, it has mentioned as obese one. So if suppose it crossed 30, automatically it is mentioned as obese. What is morbid obesity? If suppose the person is having 40 and above, the BMI is 40 and above, it has been mentioned at morbid obesity. It is mentioned as class 3, and class 4 is severe morbid obesity. That means the BMI is more than 50. So abdominal, according to the National Family Health Survey, already I told you, 30 to 39 years, it is 49.3. When coming to 40 to 49, it is 56.7. That is automatically in the age of perimenopausal or menopausal, it has been raised 46.7. And you can see that 23% of women cross the cutoff value. So we have already mentioned that once it has been crossed 25, then only they will be considered as obesity. Even they are in the cutoff rank, 23% also having abdominal obesity. Their BMI is normal, but at the same time, they are coming under abdominal obesity. So this is the way we have to identify. So persons, you may think that this female is having only BMI within the cutoff range, but if the abdominal obesity has to be found, then you have to treat them also. This is the way, this is what I want to insist. And these are all the cutoff value for Indian cutoff for indicators of waist circumference, as well as the waist hip ratio, wrist circumference, neck circumference, body fat percentage, and body mass index. We are mentioning only about the body mass index alone. No, you have to go ahead with the waist circumference as well as the waist hip ratio, wrist circumference, and neck circumference. Even you can see that the female cutoff is less than 80. If suppose less than 80, almost 70% of female may come above this only. So it has to be clearly understood that if the abdominal obesity is present, even though you have to treat the patient in a nice manner. So what are all the types of body fat distribution? You can see that if the fat distribution is only on the lower region, lower body, then it can be mentioned as lower body, that is buttock, thigh, as well as legs and all. And if suppose abdominal subcutaneous, then they will be having abdominal region alone, subcutaneous fat distribution around the abdomen. If suppose it has been covered in the all over area, these people will be having showing that I am not gaining weight in an instant manner, I am gaining slowly and steadily, the weight has been in. Actually, this will have a lot of challenges while you are treating this patient, is having lot of challenges. The last one is visceral challenge, which is highly associated with the obesity related health consequences. So you must be very careful that which type of body fat distribution the patient is having, then you can move ahead with the treatment you plan. So what are all the red flags here? Here we are having sleep apnea syndrome. The patient may have sleep apnea and unintentional weight gain, rapid onset of weight gain, or body mass index greater than 40. Already I have told you that morbid obesity and weight gain associated with the other systemic complications and cardiac arrhythmias are unstable cardiac conditions. So what are the levels of prevention for obesity? The first one, that is, the patient is not obese, but you want to prevent him to become obese. That is the primordial prevention. We have given lot of examples, and I have mentioned if suppose they are having sedentary behavior, poor diet, they may come for some other consultation. So you can educate them to advise, educate them to prevent to develop as a obese one. The next one is primary prevention, that is prevent the onset of obesity in at-risk individuals. You know that the parents are obese, automatically the children may get obese. So again the sedentary adults have to be given in a right advice to them. And the secondary prevention is the patient may have overweight or in a obese class 1, then you have to advise them to become controlled as well as to avoid complication or move on to obese 2. And tertiary prevention and manage the established obesity patient and prevent further health related complications or disability. So what are all the preventive management? Here is also we are having dietary habits, lifestyle practices. Already we have detailedly discussed in diabetes. And what are all the Siddha culinary medicines? We are having very big strength in our hand. Even Dr. Vikram is very well than me in this area, I think. So you can advise the patient, instead of having normal water, the pre-meal herbal water like cumin seeds, tulsi leaves, mint with lemon, cucumber, they can be advised to take any one of water before starting their food and all. And marudam tea, annapodi, idaya avildam, moringa rasam, kollu podi, kollu adai, samai kanji, varagu kanji. These are all the simple culinary medicines which have been prepared by themselves, and advise them to take it regularly. The detailed preparation methods and how much they have to take, one scope, how it will be, it has been mentioned in the STG itself. And fasting also, once a day fasting or moon cycle fasting, that is 15 days once and monthly once in a specific day. And honey fasting also be taken according to the condition of the patient, and you have to decide which one can be beneficial for the patient. Next, behavioral therapy. Behavioral therapy, coming to the self-monitoring techniques. You can advise the patient to take a diary on them, what are all the food items they are taking and what are all the routine work they are taking. If suppose you ask them to write, just to read for it, so after 1 week you can ask the patient to bring the diary and you can examine the diary. Then you can highlight what are all things they have done which is not right for them. So these are all the journaling, we call it as journaling. So those self-monitoring techniques can be advised for the patient. And stimulus control, that means you can make it as the plate, the eating plate can be make it as a simple and small, so they can take in a simple plot which shows that they are taking a much food. So stimulus control can be done. And sleep hygiene, you can advise them to go for a sleep hygiene. And physical activity, yoga, traditional sports, even not only normal sports, you can go ahead with any silambatam. Traditional sports can be done. And dance also, aerobics as well as traditional dance also. These are all some yogic practices for the management of obesity. So I have just listed. And again, we can go ahead with the cognitive behavioral therapy. What is cognitive behavioral therapy? So what are all the thoughts we are having? What are all the feelings we are having? Automatically, it will reflected in our behavior. So that positive reflection automatically induces our brain. Then it will come to it will have a feeling of right thing. So it is making us a chain reaction. So this cognitive behavioral therapy can induce the person to move ahead in a positive manner, and they will be stick on to the what are all the rules you are saying. So this cognitive behavioral therapy can be educated to the patients to follow. And already I have told you that as far as these diseases are correlated with one and one. 150 minutes of aerobic physical activity. And yoga practices, you are well know that it reduces weight and also manage stress. So endocrinal imbalances also it is manages, and other factors associated with obesity. So what are all the interventions? The first one is detoxification processes. Here we are coming with single herbs, Nilavagai, Karisalai, Sangam, Vilvam, Nirmulli, and compound formulation. I am not listing all the drugs, just I am highlighting only some of the drugs. And here we are having one external therapy, that is Kollu Podi Timirdal or Manjal Podi Timirdal and Tribala Churanam Podi Timirdal, as well as Putraman. The next one is review. The review should be analyze person's symptoms as well as their mental makeup, because some may expect the results in a speedy manner. So you have to assess the mental makeup of the patients, whether they are following the medicine, and all the lifestyle changes have to be examined properly, and tolerability of the ongoing treatment, sorry it's a spelling mistake, and self management support has to be analyzed. So here the referral criteria. So if suppose already I told you non-response to treatment, no change in weight or orthopimetry despite negative energy balance, even energy balance is negative, but even though they are having no change in orthopimetry, then they have to be considered for referral. And sudden loss or gain of weight more than 10%, then you have to be very careful. It's better to refer the case to the next level of health centers. And uncontrolled endocrinal profile, by investigation you have to identify anything like that, then it had the patient to be referred. And you find that suddenly the patient has gained weight, he went for morbid obesity, and evidence of an increase in severity, complications, and diagnostic uncertainty here also, and comorbidities such as cardiac diseases and psychological imbalance. Most of the patients are having psychological imbalance, so you please be careful in that, and substantial impact on their quality of life and activities of their daily living. So these are all the referral criteria. So now we are moving to non-alcoholic fatty liver disease. So NAFLD is a spectrum of disorder ranging from non-alcoholic fatty liver disease to non-alcoholic steatohepatitis, non-alcoholic steatohepatitis with fibrosis, and non-alcoholic steatohepatitis with cirrhosis and associated with hepatocellular carcinoma. So there are some stages. So this group of diseases are coming considered as, it's a spectrum, and it is considered as NAFLD. So in India, the prevalence is ranging from 9% to 35%, and some of them are having lean NAFLD. Any idea? Because they are having the BMI, just like abdominal obesity, they are having the BMI is within the cutoff range, but they are having NAFLD. So around 16 to 97% are having NAFLD with lean NAFLD in India. And what are all the associations? Type 2 diabetes and dyslipidemia both are consistently associated with NAFLD. So if suppose patient is having T2DM as well as dyslipidemia, automatically they have to be evaluated for NAFLD. And other conditions which are having associations are chronic kidney disease, obstructive sleep apnea, hypothyroidism. Some other cases are there. Just place constraint, I have mentioned only 3. And the major mortality is cardiovascular disease. Even though it has been mentioned as hepatocellular carcinoma is the final one, but before that, cardiovascular disease or cancer. Cancer is the final one when the disease progresses. But before that, cardiovascular disease is the first and foremost cause for mortality, the patients who are having NAFLD. So it has to be rightly addressed. And prevalence in NAFLD, it's around in southern India, it is high. That is 32%. When coming to western, it is 16.6, and eastern it is 24.5. So in South India, it is very high. that is 32 percentage. Can I have water? Water. Coming to Siddha. In Kaliral Noihal, we are having Yuhi Vaidya Sindhamani, a group of diseases have been. Thank you. In Siddha, a group of diseases have been classified as Kaliral Noihal. In that, a Kaliral Noi has been correlated with NAFLD in this for this, and here we can see that just I want to highlight the Siddha pathophysiology, how it can be coming to stage 4, that is Kaliral Putru. The first one is you can see due to our reduced digestive fire, then abnormal increase of alal, again kolupu increase, it leads to steatosis. Once steatosis occurs, automatically visamakini, that is toxic digestion, that is accumulation of digestive fire, then it leads to hepatic steatosis, that is Kaliral Vila allergy. It leads to, that is derangement of 3 vital humors, resulted in hepatic fibrosis, and the last one is tabidam, that is hepatic carcinoma. So this is the simple thing we can say that how the NAFLD, the final stage from fatty liver disease to it ends up with the Kaliral Putru, that is hepatocellular carcinoma. So what are all the symptoms? Actually, have you ever seen any patients with symptom of NAFLD? No. As an accidental way, we may diagnose the patient with some other disease. We have sent the patient for ultrasonogram. Then only we come to know that the patient is having fatty liver stage 1 or stage 2. So most of the patients are having asymptomatic only, and some may have this fatigue, nausea, vomiting, or pruritus. Simple conditions they may have. So with this only we are diagnosing the patients with these symptoms. And so what are all the risk factors for NAFLD? Even though without having any symptoms, just we are diagnosing the cases. So abdominal obesity, impaired fasting glucose, hypertension, hypertriglyceridemia, and decreased HDL. So again we are running in between all the 5 diseases only. So if suppose you have diagnosed one metabolic disease, then automatically you have to think of other thing too. This is what I want to insist. If suppose the patient is having high blood glucose level, high triglyceridemia, automatically you have to think of NAFLD, then the patient has to be educated in a proper manner, and they have to be followed up, they have to be treated, and the right perspective of the disease progression has to be intimated, educated to the patients. Okay. So these are all we know very well, but we have to correlate one each and everything, and we have to educate the patient. So what are all the investigations? So incidentally, I have already mentioned it, and the liver function test, the ratio of ALT and AST. Here we play a major role, and 2:1. It has been increased. The ALT has been increased 2-fold to 5-fold than AST. But it is completely revised when you are going with alcoholic fatty liver disease. The AST has been increased and ALT will be decreased. It is in the ulta. So automatically, if the ALT AST ratio is 2:1 to 5:1, automatically the patient has to be evaluated clearly and diagnosed as NAFLD. The other blood investigations are serum ferritin, transferrin saturation, abnormal clotting time. We may have a single lab result, then you have to probe and we have to identify what is the real status. And lipid profile, HbSAg, hepatitis B obviously, and ultrasonography, non-contrast CT, and MR, PDDF. So what are all the assessment of hepatic fibrosis? So hepatic fibrosis is the most important parameter for the prognosis treatment and outcome. If you are treating a NAFLD patient, then hepatic fibrosis has to be assessed. What are all the scores? That is FAST, that is fibroscan with AST level. The next one is AST to platelet ratio index score. The third one is fibrosis 4 score, that is nothing but AST, ALT, age and platelets. NAFLD fibrosis scores, that is BMI, age, AST, ALT, albumin and presence of insulin resistance and diabetes, and BARD score, that is BMI, age, AST, ALT ratio and presence of diabetes. So, a score of greater than 1 with EPRI, less than 0.67 with NFS and more than 2.67 with Fibro4 predicts the presence of advanced fibrosis, while NFS yes less than 1.4 455 and 54 score less than 1.3 suggest a low risk for advanced fibrosis. So, what are all the red flags? So, NAS associated cirrhosis, end stage liver disease, hepatocellular carcinoma, uncontrolled comorbidities, LSM more than 20, platelet count less than 150, and portal hypertension, hepatic encephalopathy, weight loss or anorexia are the red flag signs for this NAFLD. And prevention management. So, lifestyle interventions, dietary calorie management and exercise. So, the dietary calorie management is the first line, and exercise, these two has reduced the risk of NAFLD to half. So, you have to educate the patient that if suppose you are very well keen in their dietary intake with the calorie as well as exercise, automatically the level of risk is becoming half. The primordial prevention, prevent the risk factors like obesity, insulin resistance, and primary prevention is prevent NAFLD in high risk groups, and secondary prevention, detect NAFLD early. So, early detection and prevention, progression to NAS. Tertiary prevention, manage complications like fibrosis, cirrhosis or hepatocellular carcinoma, and our தேரையர் பிணி அணுகாவதி, ask them to take that திரிதோட சமப்பொருட்கள். So, interventions, obviously, detoxification procedures, single herbs, Auriver Kudineer, Adadada, Amanakku, and Kilanelli, Sivanar Vembu Karkam, Kadukai Karkam, Amukra Ilai Karkam, and compound formulations like Sarakondrai Kudineer, Pidanganari Kudineer, Mukirate Ver Kudineer, Mandura Churanam, Pavatai Churanam, like, and Pura Maruthuvam, Serangotrai, Sarakondrai Pulipatra, sorry. So, referral criteria, non-response to treatment, progression of disease to NAS, NAS-associated cirrhosis, NAS-associated hepatocellular carcinoma, any other hepatic or extrahepatic complications such as gallstone disease, commonly seen in older age group and higher grade of NAFLD, hepatic encephalopathy, portal hypertension, hematemesis or melena, any condition requiring blood transfusion or critical care management, any condition or serious complication beyond the scope of our treatment, other modalities can be considered depending on the case and to rehabilitate them properly. Yes. If you want, we can send. No problem. Oh, no problem. Yes, yes. Oh, this one. When coming to the Siddha ethical principles of management, why I have saying like that? The line of treatment may vary as the patient may approach for disease management at any level with any comorbidities, with or without comorbidities. So, you have to accept the condition first and normalize the altered or deranged humors as per our Siddha policy, and revitalization of the 7 body constitution may be the first line of treatment, and detoxification methods followed by internal medication. However, it has to be decided by yourself only. Even though we are saying that it has to be given, but at the same time, being a physician, you may think that it's not applicable for this patient because we have given Vamana Marthuvam for NAFLD. But if the patient is not able to take Vamana Marthuvam, then you are not saying that you have to skip it up and you have to choose the other thing, that's all. So this has to be decided by your own. And the level 1, level 2 medications can be used for level 3 also. There is no restriction that level 3 medicines alone can be introduced to the patients in the level 3. So these are all the things this you have to keep it in mind. So follow up. So why I have mentioned in the separate slide is follow-up is very much important. If you fail to follow any cases, then there is no use to put our efforts in that. So follow-up is very much important, and monitoring the person's symptoms and the ongoing impact of the condition on their activities of daily living and quality of life is very much important. And monitoring the signs and symptoms, diet, daily activity, change in weight, anthropometry, as well as blood glucose level. What are all the basic investigations you want to do that has to be rightly done in a right time. And assessment of energy balance, assessment of motivation levels to continue with the lifestyle modification. Here lies our big challenge. We have to make the patient, educate the patient to follow the lifestyle modification what we have advised him, and monitoring the long term course of the condition. It is not an easy thing going with over a period of 1 month or 2 months. It will be go ahead with the long term course. You have to engage the patient for a long term, and discussing the person's knowledge of the conditions, because this time patient may come and he can hear you and he can follow this. Once he left and automatically go back to his home, someone else we educate and someone will intrude into that, and they may decide something else. So they may ask multiple questions. So so the person's knowledge of this condition is very much important. So first time itself you have to educate them properly what is the real scenario and how the disease will progress if suppose he is not taking the medicine in a right way, and follow the rules of dietary modifications as well as lifestyle changes. And better to ask them for their personal preferences. That's why Raghu sir said told that the informed decisions must be taken by the patient himself, not by ourselves. So you have to educate them. The personal preference should be before starting medications. Please ensure that the preference of the patients, and reviewing the effectiveness and tolerability of all treatments and self-management support. So what is the take home message? So do opportunity screening wherever possible, and examine comorbidities and active treatments. If suppose patient is, if suppose you are receiving some patient who is already in standard of care, don't say abruptly to stop the medicine. Wherever possible, wherever necessary, just ask them and recommend them to follow the standard of care. Just add on, give as an add-on therapy, you can give the medicines, but before starting or tapering the dose, please be ensured that it has been intimated to the conventional treating physician. You can get their opinion also. Don't hesitate to communicate and get their opinion in reducing or stopping the medicines and all. Just do communication and a close association, and clear on red flags before initiating the treatment. Stick on to the facts and accept the truth. If suppose we are treating the patient, we are not getting the result, just accept the fact and accept the truth also. Just don't be stringent and insist them to follow this thing. If suppose it is that this patient, honestly you are thinking that this patient has to be referred, then honestly just refer to the higher centers. Understand your role and be optimistic, and treat, document, collaborate, and disseminate. This is what we need. And I wish to acknowledge our respectable DG, Professor Dr. N.J. Muthukumar, CCRS, for this opportunity, Ayush Vertical Ministry of Ayush, and CHEB New Delhi for this wonderful opportunity. Thank you one and all for your patient listening. Any queries? Is their strength. we are having that it have slow glycemic index, then only we are advising the patient to take take the varieties. But when it's get porridge, automatically it has been crushed, so the glycemic index is going high. They are not receiving the complete quick absorption. Yeah. Yeah, again it will, the glycemic index will be maintained. இதய அவிழ்தம் nothing but வெண்தாமரை, வெண்தாமரை as well as செம்பருத்தி. It has been with palm jackery, it has been make it as a balls, and it can be taken morning and night continuously. The preparation methods has been mentioned in the book itself. Published in the last November itself. So ICD-11 code is rightly available in the online. So you can take ICD-11 traditional module 2. In that Siddha also we are having ICD-11 code. When we are preparing this document, that was not available. That's why we are not putting ICD-11 TM2 code is not putting here. We have mentioned only ICD-11 code. We are having our own traditional module code is available, under which we are having Ayurveda, Unani as well as Siddha. Also, for that we have put all the codes of TM2.
So it was an excellent session for the past 2.5 decades.
Okay.
In spite of it, we do have lack in the knowledge.
Okay.
And your lecture definitely it has provided insight for us to fill the post questionnaire.
Thank you.
Excellent, madam. Thank you.
Just a recap only,
Yes,
because
yes.
being a physician, practicing physician, you all know very well than me. But as far as we are doing our routine practice, we are not going back to our book and we are not seeing all
we
those
have
things.
to get ourselves updated.
Yes, that's all I need.
Thank you.
Okay,
Thank you.
thank you.
Thank you, madam.
Any other questions?